Good morning, everyone. My name is MAYCHAM. I'm on the MAYCHAM Advisory Council and also sponsor of the MAYCHAM Women Internal Network. First of all, I'd like to thank everyone for joining us on the call. As we start 2021, we ask ourselves, what is the one thing that has gripped all our lives in 2020? Well, there are no prizes for guessing. The answer will be unanimously COVID-19. So as we embark on a new year, there is a great deal to celebrate with the development of the vaccines at record speed. However, I think for many of us, there are many questions about the virus, the vaccine, and how we cope with the new normal. With that in mind, the first Women Network event in 2021 is Living with COVID and What You Need to Know. Before I introduce the speakers, please let me set the ground rules. This is a private information sharing with members of the chamber, and the views expressed are those of Professor Malik and not HKU. So Chatham House rules apply, and if you wish to approach Professor Malik, please approach him separately and ask for his permission. So with the housekeeping out of the way, let me first introduce Professor Malik Paris. Give us a wave. Professor Malik is a renowned pathologist and virologist. Born in Sri Lanka, he has been based in Hong Kong for many years. He's currently Director of Influenza Research at HKU, and Professor has been involved in many decades of research into many types of virus, and in 2003, he played a very key role in the discovery of the SARS virus. Given his extensive experience and knowledge, Professor Malik continues to serve on many committees in Hong Kong and internationally in conjunction with WHO. Let me run through today's agenda very quickly. Professor Malik will set the framework for today's knowledge sharing with a 10-15 minute talk. This will be followed by an hour-long interactive session facilitated by Professor Kathy Chia. Kathy, give us a wave, is from Penang, is a MAYCHAM member and has been based in Hong Kong for many years. She's Chair Professor of Biochemistry at Hong Kong U and specializes in molecular genetics. We've received many questions prior to the event, and Kathy will pose those questions and her questions as well to Professor Malik. So I would like to thank both professors for joining us today, and over to Malik. Thank you very much.
Hi, thank you for that.
Hey, before we start, do you need to say something about if there are additional questions from the audience? How do they go about doing it?
Yeah, there is going to be a chat box. So if you've got additional questions, so as and when the Q&A starts, you may have additional questions. So please feel free to post that, and we will pass it to Kathy. Can see it, but we will also post it to her to make sure that your answers are your questions are answered. Okay. Thanks, Kathy. Okay, over to Malik.
Okay. Good morning to all of you. I'm speaking to you from quarantine in Hong Kong. So I'm serving my sentence of 21 days. It's a pleasure to be with you, and I'll try to give a very short background presentation, but leave more time for questions and try to respond to the questions. So let me first share my screen. Yeah. Yes, so the title was Living with COVID. And I think this is quite an apt title because we will be living with this virus for a long time to come. It is not going to disappear, whether it be with vaccines or anything else. Right, so firstly, some issues about how it is transmitted. This is, in fact, a study done from our School of Public Health here at Hong Kong U in collaboration with the Chinese CDC in the very early stages of the outbreak. And what you see here, this red line, is the time of onset of symptoms. And this curve shows you the proportion of people who transmit at different stages of the illness, before the onset of symptoms and after the onset of symptoms. So what you can see is that about 40% of transmission takes place before the patient develops any symptoms, before he or she knows that they are ill. And that is fundamentally important. It's a key problem in control of this disease. Then another 40–50% takes place of transmission takes place within the next 4 or 5 days after onset of illness. So this is really the challenge. How you prevent transmission of a disease from people who may be perfectly healthy, and in the very first days after developing symptoms, when they may be still thinking it's quite mild and not going to seek medical attention. Now, this is very different to the situation with SARS. In SARS, I've just schematically illustrated it here. There was no transmission before onset of symptoms, very little transmission in the first few days after onset of symptoms, and most of the transmission was taking place around day 6, day 7, day 8. So there was a much wider window where you could detect these patients, get them into hospital, out of the community, and break transmission. And that's exactly how SARS transmission was stopped. There was no vaccine at that time. There was not even proven antivirals. So it was purely stopped by these public health interventions because of this fortunate situation with SARS, which unfortunately we don't have with COVID-19. This pattern is very similar to what you see with the common influenza. So that is one problem, one challenge to tackling transmission. The other challenge is shown here. So with SARS, what you see in terms of the pattern of disease, as you know, for most infectious disease, you have a spectrum of disease. You can have severe disease, you have mild disease, you have asymptomatic infection. In the case of SARS, the pyramid was more or less standing on its head like this. So most of the cases were severe, so they very quickly came to medical attention. A few of them were mild. There were very few that were asymptomatic. In the case of COVID-19, it is exactly the opposite. Most of the cases are mild or asymptomatic, and only a small proportion of them are severe. So these two taken together is the challenge that COVID-19 poses for control of transmission. Now, how is COVID-19 transmitted? As you know, people who are infected do release virus-laden droplets and airborne particles when they cough or sneeze or talk. And of course, more than talking, if you're talking loudly or you're singing, so that increases the spread of these infectious particles. There are larger particles, which of course carry more virus, but they do not travel very far. So within 1 to 2 meters, because they are heavy, they fall to the ground. So these are what we call large droplets. But the finer airborne particles, as they leave the mouth of the person or nose of the person, can evaporate very quickly so that they essentially become weightless and they can be carried in air for quite a distance. Having said that, you still have to keep in mind that there's a dose effect. So closer you are to the infected person, the higher the dose of infection you will get. And you have to keep in mind that just a single virus particle is not enough to initiate infection. Most recent studies estimate that you need about 1,000 infectious virus particles to initiate infection. So the dose that you get exposed to is fundamentally important. And this is why most of the transmission takes place by exposure over a 1 to 2 meter distance. Although there are some instances, very occasional, where transmission has taken place over a longer distance. Now, in addition to that, there is the indirect route of transmission. So for example, if somebody is talking, coughing, and contaminates a table or contaminates their hands, and their hands then contaminate another surface. So for example, the some surface on the public transport or whatever it is, the virus can stay alive. It doesn't replicate outside the body, but it can persist alive for a period of time. And that depends on the type of surface. If somebody else then touches the same surface and then touches their nose or eyes or mouth, you can transfer infection to yourself. And that's the indirect route of transmission. And that is why hand hygiene is so important. Now, the survival of virus is quite long in smooth surfaces, such as glass or stainless steel, or maybe a plastic tabletop. It is much shorter on porous surfaces, such as paper and wood. Right, so how do we prevent transmission? And this is where wearing of face coverings, something like a surgical mask, is very important, because it will, and we have in fact shown this not for COVID-19, but for other coronaviruses, studies done in Hong Kong itself, that it prevents these infectious virus particles coming out of the infected person's mouth. So it is not only that you protect yourself, we are also protecting each other. Now, this, I think, is a message that people like Donald Trump seem to have forgotten when they think that they are very macho by not wearing a face mask. What they're doing is not just saying, I'm not scared of SARS. You're also saying that I don't care what happens to you. So that, unfortunately, is the message that has not got through to everybody. So the wearing of face masks is fundamentally important, of course, to protect yourself, but also to protect others from you, because you don't know whether you're carrying the virus asymptomatically. You don't know whether you're carrying the virus pre-symptomatically, meaning you will get symptoms in a day or two, and that is the period, as you saw from the previous graph, that you are most infectious. So face masks do help. Then, of course, as we talked about transmission by the indirect route through hands, hand hygiene is important. So clearly, especially when you're out and about, when you're outside your own house or room or whatever it is, and you're touching publicly accessible spaces, you have to keep in mind that your hands may get contaminated. So do not touch your eyes, nose, and mouth until you can clean your hands either with an alcohol hand rub or with washing with soap and water. Right, so now a major topic of interest is the vaccines. Now, how vaccines work is that they mimic the natural infection, because as you know, for many infectious diseases, once you get infected, you are then resistant to reinfection. And here I'm showing you the sort of a schematic virus particle here and also here. these spikes on the surface of the virus are fundamentally important to the virus, because that is how the virus attaches to the cells of your body and gets into your cells. And here is what happens when you have been infected in the past and you develop antibodies. So these Y-shaped structures here are antibodies, which are part of the immune system of your body. And if these are specifically raised to this virus, particularly these outer spike proteins, the outer proteins of the virus, they will bind to these proteins and then prevent the virus entering your cells, that is, and infecting you. So that is one mechanism of transmission. There are also other mechanisms of immunity. I'm sorry, not transmission, I'm talking about immunity. So that is one mechanism of immunity, which is antibodies, but there are also other mechanisms of immunity as well. But the most important measure that we are focusing on at the moment is the detection of antibodies. And this we can easily measure in the blood of a person. Right, so how can you develop these antibodies without getting infected, right? Now, because if you allow the infection to spread in the community without any check, then it will spread, many people will get infected, and there will be immunity in the population. But that will be associated with a level of hospitalization and death, which is totally unacceptable, as you can see in places like the UK right now. So how can we achieve this immunity without getting infected? And that is through immunization. Now, previously, conventional vaccines for viruses have taken a couple of strategies. One is you can grow the virus in the laboratory or in a manufacturing plant, kill it so that it is no longer infectious, and inject it. And through that process, you're exposed to these virus proteins, and the body will make antibodies to the virus and block infection. Another, so there are many vaccines that use this strategy for a long time. Indeed, it's a very conventional strategy for developing vaccines. Another strategy for developing a vaccine is to take the virus and make it weaker so that it can infect you, but it is not potent enough to cause disease. Now, again, there are a number of vaccines that use that strategy. So the measles vaccine, the old oral polio vaccine, the mumps, rubella, chickenpox vaccines are all of that nature. Alternatively, you can take bits of the virus, particularly key parts, such as these outer proteins of the virus, which I told you are fundamentally important to the initial step of infection, and manufacture that and inject that so that you will make antibodies to these key proteins. And again, you'll achieve this same purpose. Now, in the case of, in addition to that, there are more novel approaches to vaccine development. One is to use the genetic information in the form of RNA, which is essential to manufacture this protein, this virus protein in your body. In our cells, as Kathy will clearly explain to you, she's an expert in this area. All the proteins that we make in our body are coded for. The information comes from DNA, which is in our genes, which an intermediate molecule called RNA, which codes for the instructions to make a particular protein. So rather than injecting the virus protein itself, you can inject that piece of RNA that will code for your cells making this viral protein. So this is the basis for these RNA vaccines that I'm sure you have heard about. Alternatively, you can introduce the genes that are necessary for making this protein in another mechanism using, if you like, another harmless virus as the carrier, as we call it, the vector, to introduce this particular piece of nucleic acid to code for the production of the viral protein that we desire. So in most of these cases, when we are talking about the viral protein we desire, it is this protein on the surface of the virus, what is called the spike protein. So what about the COVID vaccines that are now available? Just to finish this story. So in both these strategies, whether it be the RNA vaccine or these adenovirus vectored vaccines, your own cells are the factory that make the viral proteins that we want. Now, there's been a lot of misinformation in the internet and in these social media platforms, which says that these RNA vaccines are very dangerous because the RNA will get integrated into your genes and your DNA, and it will cause permanent damage to your genetic makeup. This is absolutely untrue. And again, I'm sure Kathy will be very able to explain why this is not possible, because RNA cannot get integrated into your DNA. There is no way that that can happen in a normal human cell. So these RNA that is injected as part of the vaccine lasts for a short period of time. It will do its job in coding for the production of the viral protein of interest, and then it will decay and be degraded. There is no chance that this RNA vaccines are going to permanently alter your own genetic makeup. Right, so what are the COVID vaccines that we are currently talking about? They use a number of these strategies. So firstly, the conventional strategy of growing a lot of virus, killing it and injecting that as the vaccine, that is what is used by two of the Chinese vaccines, Sinovac and Sinopharm. So that's a very traditional approach to vaccine development. Ready-made viral protein, again, there are a number of vaccines that are using that approach. They are still in late clinical trials. They are not coming close to the market immediately. Then, of course, these RNA vaccines, very much in the news from Moderna and Pfizer-BioNTech. And finally, these adenovirus vectored vaccines, sorry, there are a number of them. AstraZeneca, the Oxford vaccine, there's a Chinese vaccine, there's a Russian vaccine, and also another vaccine from a major pharmaceutical company called Janssen. Now, although all of them are using adenoviruses, there are some differences which, and I will, if you want, explain that in a bit more detail, but the problem is some of these adenoviruses also infect normal humans. So adenovirus 5 is very common in the human population. So this, if you use adenovirus 5 as the delivery mechanism to deliver the vaccine, some of us may be having antibody to adenovirus 5, which will knock out the vaccine before it gets into you to do its job. So this is why the Oxford group have used this chimpanzee adenovirus, which obviously doesn't infect humans. And the Russian vaccine uses a very uncommon adenovirus, adenovirus 26, as well as the Janssen vaccine uses adenovirus 26. So much less chance of you having pre-existing antibody that will zap the vector before it can do its job of delivering the vaccine to your cells. Now, there's another major question and debate as to how is it that these vaccines were developed so quickly. I mean, within a year, they went through from 0.0 to licensure, at least for emergency use authorization. As you know, normally it takes many, many years for a vaccine to be developed. There is the preclinical studies that are done in the test tube, done in animals. Then there is a phase 1 humans trials where humans are injected with small doses of your putative vaccine and you look for safety. Once you go through that, you go to phase 2 clinical trials where you then look for further safety, but you also then look for the immune response to the vaccine. And once you go through that, you then go to phase 3 studies where you recruit large numbers of people and you see whether they are protected by the vaccine. So this whole process normally takes many years. The reason why the COVID vaccine development has been able to be done in a relatively short time frame is, first and foremost, the platforms, the techniques for developing the vaccines for COVID-19 are not new. All of the platforms, including the RNA platform, the adenovirus vector platform, they have been used before. Although they have not been used for licensed vaccines before, they have been in use for a number of experimental vaccines which have gone into human clinical trials before. And of course, the conventional strategy of growing and killing the virus has been used before as well. So the techniques are not completely new. It is just that they have been switched to this new virus. That is one reason. The second reason, of course, is because of the urgency of the situation. These 3 phases were telescoped one over the other to minimize the delay without compromising safety. And of course, another big part of the delay is after a vaccine is shown to be effective, then it takes up quite a long time to scale up the pharmaceutical industry to make this at scale. And in order to avoid that, a number of governments and WHO and organizations such as Gavi, which is supported to some extent by Bill Gates and other charitable foundations, did make advanced purchases of vaccines even before they were known to be effective or safe. So in other words, allowing the companies to start manufacturing vaccines even before they knew whether the vaccine will work. So because of that, that has allowed vaccines like Moderna, Pfizer, the Oxford AstraZeneca vaccine to be already ready by the time the clinical trials were completed. So these are the reasons why the vaccine development has been able to be accomplished in a short period of time, not because any of the safety steps have been circumvented or shortcuts taken. Now, here I have just summarized some of the vaccines that are currently available or likely to be available in the next few months or during this year. As you know, there is the BioNTech and the Pfizer vaccines, which are both RNA vaccines. The AstraZeneca Oxford vaccine, which I said is an adenovirus-based vaccine. And we have another adenovirus-based vaccine here, which is the Russian one. And then the 2 Chinese vaccines, which are the conventional strategy of growing virus, killing it, and injecting it. For 3 of these, we do have scientific papers published. So for the BioNTech, Pfizer-BioNTech, for the Moderna, and for the AstraZeneca Oxford vaccine, the phase 3 clinical trials have been completed, scientific papers published, so we can see in detail the underlying basis on which the claims for efficacy and safety are made. For these 3, these vaccine efficacy data is reported in the media through press releases, but we haven't seen the data published in any detail. So we have to basically take it at face value. Although some of the safety data for these Chinese vaccines have been published, the efficacy data is essentially what different countries are reporting without us being able to examine the clinical data, the research findings in detail. Presumably, they will become available in the weeks ahead. Now, there are also some practical differences in these vaccines. Particularly the Pfizer vaccine has to be stored at ultra cold temperatures. I'm sure you have heard about this in the media. So that poses some challenges, and not for Hong Kong. I'm sure for Hong Kong that will be quite manageable, but for even for other large developed countries, even USA, UK, it is still posing some logistical challenges because not every pharmacy, not every GP's clinic will be able to have this type of ultra cold storage. The Moderna vaccine is a bit better, but still requires special storage at -20, which is the kind of freezer temperature you get in your home refrigerator. The other vaccines, including the AstraZeneca and these other Chinese vaccines, are much more like normal vaccines, which can be stored in a normal fridge type of temperature. And most of these now have been licensed in various countries. As I've shown you, there are price differences. So these the Pfizer and the Moderna vaccines are quite a bit more expensive than, say, for example, the Oxford vaccine. Right. So with that, I will stop, and will be happy to take any questions. I will stop sharing the slides, I think, if I can do that. Yeah. Over to you, Kathy.
Thank you, Malik. That was a very, very useful, informative talk, and I'm sure it has helped people to understand more clearly all the issues. So I think we will start off the question and answer session by dealing first of all with the questions that we received prior to the webinar, and then move on to the number of questions that have been received under the Q&A box. So the first question that was received previously is, given the new strain seen in the UK and South Africa, people are concerned, and there are rumors that the vaccines that have been developed will not work against this strain. Is this true?
Right. So as you know, viruses, particularly viruses that have RNA as their genetic base, which includes coronavirus and influenza, these viruses do have a high rate of mutation, meaning they have the capacity, therefore, to escape anything that we can throw at them to block, for example, things like immunity in the population. So this is why, for example, in the case of influenza, we need to update the vaccine every year. Now, fortunately, coronaviruses, the mutation rate is much slower than influenza, but still it is significant. And so this was inevitable, I suppose, that we would see some mutations of concern. Now, mind you, mutations have been going on right from the beginning of the outbreak, but most of these mutations were not of any biological concern to us. But these ones, the ones that are now being reported in the UK and the ones from South Africa, are concerning because they are in this key spike protein that I told you is crucial for the attachment to the human cells. And that is also the key protein that is targeted by the vaccines. So that is why these mutations are of some concern. So the information that we have so far on the UK mutant is that it does seem to increase transmissibility, meaning it is spread more rapidly, which means that we will have to work harder to reduce its transmission using the same social distancing, physical distancing, etc. measures that we use. That is pretty clear. Now, whether it will escape vaccine immunity is still being worked on, but from what we can piece together, that doesn't seem to be a major risk, but we are still waiting for the final data out of the UK on that. The South African virus, again, seems to be able to spread more efficiently. But the question of how much it will affect vaccine is a bit more concerning because of previous information that we have on one of the mutations that are present there. Now, even if that is the case, that it does have some effect on vaccine efficacy, it won't be a complete loss of vaccine efficacy. However, as I said, the first and foremost and very clear problem that we have with these mutations is increased transmissibility. And that does pose problems for control. Having said that, when you're talking about the social distancing measures for control, it doesn't mean that these measures don't work. It just means that we have to work harder, use more stringent measures in order to achieve the same goal. Over.
Okay, thank you very much, Malik. I hope that answered the questions for the person who asked that. I'm going to group
sorry, Kathy. Can I just before I forget, I'll just want to add something. So even if it does turn out, as I said, I mean, these mutations are unlikely to completely lose vaccine efficacy. But even if that does happen to be the case at some point, many of these vaccines, especially the RNA vaccines, the adenovirus vectored vaccines, are quite easy to tweak to make that particular mutation so that we can have a second generation vaccine, without having to go through all these phase 1, phase 2, phase 3. It'll be a minor tweak in the vaccine, which will hopefully restore vaccine efficacy. So that is, of course, for the future. Over.
All right, thank you. I'm going to try and organize the questions in terms of the subject matter so that they will be more related rather than go through them in order. So for those of you who have put your questions in the question and answer Q&A box, don't think that I've forgotten about your question. Okay, so related to this answer, there is a question from Eugene who says, my question is, what does 95% vaccine efficacy mean? And does this mean that I can still get infected if I happen to be in the 5%?
Yes, I'm afraid in life, nothing is 100%. I mean, if we step out of the door and, go on the road, there's always a statistical chance that we'll get knocked down by a bus or a car or whatever it is. So, so there is a risk in everything we do, but I'm not trying to be too dismissive of that point. That is true, but the data that we have so far on these vaccines, Pfizer, Moderna, and the AstraZeneca, although there is a 5% chance of you getting infected, none of those infections in those clinical trials led to serious disease, right? While there was some serious disease in the control arm. The control arm meaning the group that did not get the vaccine. So it does seem that you have even better protection from severe disease. You may have 95% protection from getting mild disease, but it seems that you have even higher chance of being protected from severe disease. So, I think that is how we should interpret these results. And also, we cannot just look at this 95% compared to 80%, compared to 60%, and just say that one vaccine is better than the other, because these vaccines were not compared head-to-head, right? So they were not compared in the same populations with the same risk of infection, etc. So I think what is clear is that at least those three vaccines, that is the Pfizer-BioNTech, Moderna, and AstraZeneca, do have quite acceptable protection. I must say that if at the beginning of or middle of last year, somebody said that we would have a vaccine that is 70% or 60% protective against COVID, I would have been delighted. And I'm not alone. I think everybody in the field would have been delighted. Keep in mind that the influenza vaccine, most years, actually in the best years has about 60% protection. In the bad years, it is much less. So although, of course, if you take a vaccine like measles, that is in the 90-95% protection range. So as vaccines go, these trial data are incredibly promising. Having said that, we have to keep in mind that these levels of protection that we are seeing is only a short time after vaccination, pretty soon after vaccination, right? So we don't know how long this protection will last. But coming back to the question specifically, it is true, there is still a 5% chance you'll get infected. But as I said, what it appears to be is that even if you get infected, if you have been vaccinated, the chances are that you will have a much milder infection than you otherwise would have got. Over.
Thank you. That was very helpful. And related to this again about safety and efficacy, I guess you have partially answered the question, but there was a question asking you to compare between the, say, Sinovac, Pfizer, Moderna, and AstraZeneca, the safety and efficacy of each vaccine. You sort of answered that, but perhaps I guess they wanted something a little bit more definitive. Is which would you regard as being safest, or are they all about more or less the same?
Right. So in terms of safety, and I think safety is probably the first and most important thing you have to look at, right? I mean, obviously. So in terms of the data that has been published so far, and as I said, we have much more data on the first three, that is the Pfizer, the Moderna, and the AstraZeneca, because the phase 3 clinical trial data has been published. So just to explain, the numbers of people who are involved in these clinical trials in the phase 1 is very small, phase 2 is a bit larger, a couple of hundred, and in phase 3, it is tens of thousands, right? So the side effect profile that we have from phase 3 clinical trials, which are published, really come from those first three. So the Pfizer, Moderna, and AstraZeneca. And on the basis of that, they seem extremely safe as vaccines go. Now, there will be always some side effects with any intervention, any medicine, any drug, any vaccine. There will be rare side effects. And as you know, in the case of both Moderna and the Pfizer vaccines, there are very rare instances of allergic reactions, quite severe allergic reactions, particularly in people who are known to have an allergic history, meaning people who have had what are called anaphylactic reactions to, so these very serious allergic reactions in the past to types of foods and things like that. A small proportion of these people seem to get quite severe reactions to the vaccine, but this is completely treatable. So the important thing is, of course, if you do have a history of severe, what is called anaphylactic allergy, mind you, allergies are quite common. I mean, many of us do have allergies. I'm talking about the type of allergy where, for example, for some people, they eat seafood, and then within a few minutes, they can't breathe, they are choking, the mouth swells up, and it's really life-threatening, right? I'm talking about that type of allergy. If you have that type of allergy, then you should discuss with your doctor whether it is safe to get those two vaccines. But it's still a question that even if you do develop such a side effect, if you are within a medical facility, the treatment is quite effective, right? So, but nevertheless, that's something you'll have to think about. Now, for the other two, for the other vaccines, as I told you, the Russian vaccine, the two Chinese vaccines, the phase 3 clinical trial data have not yet been published. I mean, we are told that they are safe, but we haven't seen the data in detail. So we have to wait and see until those data are published. But in the phase 2, the smaller sized trials, again, there was no major concerns that were noted. So it seems that these vaccines are all safe with the proviso that I told you, that we are waiting for the detailed publication of the latter 3 vaccine safety and efficacy data. Over.
Okay, thank you. That was very useful. So that's with the extreme immediate allergic response, but it's another question that's received regarding safety again. This question is: a 56-year-old Florida doctor died after getting his COVID vaccine. After the shot, he developed immune thrombocytopenia. How worrying is that?
Yes, so that definitely is concerning. That is being investigated. It was, I think, after two weeks, 15, 16 days after the vaccine. It is quite a rare side effect for a vaccine. I mean, it's not, it has been reported with other vaccines in the past, but it's extremely unusual. And of course, you can get these types of conditions anyway. You know what I mean? I mean, it is quite possible that the person, whether he was vaccinated or not, was going to develop this because of some other infection that he got in the meantime. So that is being investigated as to whether that is related to the vaccine or not. And there will be other such events. I mean, you know, when you're rolling, keep in mind that by now, there is, I think, probably more than 2 million doses that have been given in the UK and the USA, right? So inevitably, there are going to be very concerning events that happen to people when you give any intervention. I mean, you know, even if you gave water to 2 million people, a few of them are going to have some event happening within the next couple of weeks. So you have to distinguish between vaccine-related events and other events. But I mean, it is possible that this is unrelated to the vaccine, but it is also possible that it is related to the vaccine. So this is something that will have to be investigated and will be reported on in due course. But again, you have to keep in mind the scale of the event. So I mean, if it is a 1 in a million, then of course that is something we have to factor into the decision of whether you want to take a 1 in a million risk compared to the chance of you getting COVID, and depending on your age, your underlying diseases and things like that, the risk of having serious complications and, you know, even death from COVID, once you're over 70, 80, it becomes very, very substantial. So I think so these are the risks that we have to balance, of course. Over.
Thank you. And so again, relates to lots of questions about the safety. Considering the different methodology the vaccines are made, are there any safety issues in the long term? So those are sort of like rare events, but are there any long-term safety issues that we should be concerned about?
Well, if you talk about long-term safety issues, theoretically, there could be things like autoimmune diseases where indeed, idiopathic thrombocytopenic purpura is also a type of immune-mediated disease, which of course, in this case, if it was related, happened quite quickly. Whether you can have something, you know, much longer than that, I suppose people are thinking about these allegations about, for example, autism and things like that related to vaccines like measles and mumps. And I just want to reiterate that all those allegations have been completely disproven. So, I mean, you know, that type of long-term effect with vaccines, such as these long-term neurological damage, is complete bunkum. I mean, to put it mildly, and the person who brought these forward, Andrew Wakefield, has been struck off the medical register, and he has been completely disgraced. But the damage that has done in people's minds still remain. So that damage is unfortunately permanent for many people. So that is exactly why these are so problematic. So I think the side effect issue is primarily a short, medium-term issue. I mean, if you are going to develop some adverse effects, it's going to be within a matter of a couple of weeks at most. I don't think there's a realistic chance of you developing something 1 year or 2 years later.
Thanks. So again, related to safety, there's a question received saying, are these vaccines harmful for those who are getting pregnant or already pregnant?
Yes, so as you will see, these vaccines are not recommended for people who are pregnant. That is not because there's any evidence of any adverse effects, but this is routine, whether it be any new vaccine or drug for that matter. In the first phase, until there's much more data accumulated with millions and millions of people getting the, in this case, the vaccine, they will not recommend use in pregnant individuals. Then, of course, there's also the risk that even the sort of mild fever, and you might feel aches and pains and body aches and things like that, whether that may have a adverse effect on pregnancy, we don't know. So it is for those reasons that it is not recommended for use in pregnancy. But if somebody has taken the vaccine and then subsequently gets pregnant, there is no real reason to be concerned about the pregnancy, because as I explained to you, it is not that there is any reason to believe that these vaccines will be harmful in pregnancy. It is just a matter of precaution. For the same reason, these vaccines are not licensed in children under 18. Again, not because there's any reason to believe that they would be harmful, but because the clinical studies have not been done in these individuals. So in due course, the clinical studies will be done in children and at some point also in pregnant women, and then we will have more information. But for the moment, they are not recommended in pregnancy.
Okay,
Over.
Thanks. And people are interested. Henry Hui would like to know how long these vaccines are effective for. Do we have information about that already?
Right, so that's a good question. So as I told you, the clinical data we have now is very short term for out of a matter of necessity, because everybody was eagerly waiting to see if the vaccines are effective at all. Now, how long the vaccine immunity will last? There are ways of looking at it. I mean, you can actually measure the levels of antibody and look at how long that lasts. But again, the time interval is quite short, right? Now, one thing we can look at is how long the immunity, or if you like, the antibody, which is what we can measure, lasts after natural infection. So that is something we have done indeed in Hong Kong. We have just published a paper a few weeks ago looking at the duration of neutralizing antibody, that is protective antibody, following natural infection, because there were some of the earlier papers coming out saying that this was waning, this was disappearing very quickly. So what our study showed is that actually, of course, antibody levels rise after infection and then they start to come down, but not any faster than one would expect. So, so in the case of COVID, there is nothing to suggest that these antibodies are going to disappear much faster after natural infection. And indeed, from our study, we could also show that the older population have quite good antibody responses. That they are no worse than the younger population. And that is also the preliminary data from the vaccines, both in terms of antibody response and in terms of protection, which is great news. So, yeah, so how long the protection will last, I think is clearly one of the big questions that we have to monitor as we go forward. And we can monitor it by also measuring, the blood antibody levels in the population who were vaccinated. Over.
So also then again, you know, concerns about which of the vaccines is safer. There's a question says that there are news that the China vaccines are safer than Pfizer or Moderna, as the former works by using killed virus particles to expose the body's immune system to the virus without risking a severe disease response. So what are your thoughts?
I don't think that that argument necessarily follows. I mean, you know, you can theoretically you can argue things both ways if you want. So on the one hand, of course, you could say that these Pfizer and Moderna they are new technologies, the RNA technology. So because of that, you know, one might wish to be cautious. I, for one, have no hesitation knowing the mechanism by which this works. There is no inherent reason why that strategy is going to be any worse than, indeed, I would argue that it would be, because it's more targeted and more specific, it could be safer than the conventional strategy. The other difference between the RNA vaccines and the adenovirus vaccines and the inactivated vaccines is that the former, meaning Pfizer, Moderna, AstraZeneca, they are targeting one protein of the virus, this so-called spike, you know, the spikes that on the surface of the virus. So they are very targeted because we knew that that is the key Achilles heel, the key target, the protective target of the virus. Whereas the killed vaccine has lots of virus proteins, probably 40, 50 different proteins of the virus in there. Now, so on the one hand, you could argue that, well, you know, why make antibodies to all these unnecessary things when we are only interested in protection through this key protein? So that is one side of the balance. On the other, because of course, I mean, these antibodies to these other things may potentially have a theoretical risk. I mean, you know, you have antibody to one, you may have a risk of some adverse effect. You have antibody to 20 things, you may have, you know, increased risk of adverse effects. Now that is on the one side. In other words, what I'm saying is targeting very specifically to the protective protein, single protein, theoretically can be better. On the other side, of course, as I told you, antibodies are not the only protective mechanism. There is this whole business of cell-mediated immunity, which involves all the proteins of the virus. So it is quite possible, again, the data is not available yet, that using the whole virus vaccine with all the proteins of the vaccine may be much better at inducing cell-mediated immunity and a broader immunity, if you like. So particularly in the context of virus mutations, which are escaping, you know, this key target that all of us have been aiming at, having a broader range of virus proteins may turn out to be advantageous. So there are pros and cons on either side. You know, I think at this point, it's difficult to necessarily come down on one side or the other. Over.
So do you think then that if you are mounting an immune response to more spectrum of proteins seen on the virus versus a very targeted one, that this might actually also affect the efficacy? I guess we don't actually have information about that yet either. So might it be more efficacy for the spike protein vaccine than the whole virus? Might it be more effective or not? We don't know, right?
Well, yeah. I mean, well, we don't know, right? I mean, at the moment, on the basis of the so-called efficacy data that people are coming out with, as I told you, these are not published. I mean, Sinopharm ranging from 79 to 86% and Sinovac from 65 to 91%. So, I mean, like I told you, I mean, you can't just compare these percentages just like that. But, I mean, you know, there are theoretical reasons why the targeted approach might be better, as I told you, particularly from the point of view of safety, because you're introducing only one protein into the body. But on the other hand, there are theoretical reasons why the conventional method of using the whole virus with a whole bunch of proteins might be better in terms of immune response, particularly if you are in the context of mutations where the virus continues to escape, you know, this key single target. So I think at this point it's difficult. It's difficult to know. Yeah. So I think, you know, both approaches probably do have advantages, and time will tell which might be the best. And mind you, we have to keep in mind that what we are talking about now is the first phase, if you like, the first versions of COVID vaccines. There are a whole bunch of vaccines coming along, which are using various strategies, which might have other advantages, and indeed, maybe in due course, we might want to use different strategies as well. So I think, you know, at this point in time, I personally would be really looking for, first and foremost, safety, and secondly, protection for the next 2 years or so. In 2 years' time, I think we will have a whole range of other options becoming available. We'll have much more data becoming available. And of course, there's nothing to stop us taking any new vaccine that comes along, depending on need. Over.
So I guess there's still lots of things we don't know. So one question received is, would it be safer not to be vaccinated since fatalities are relatively low? That means to vac or not to vac, that's the question.
Yeah, so I mean, it depends on, you know, your individual circumstances, right? So I mean, if you are in the older age groups, the severity and fatality increases exponentially. So that, you know, so once you're over 50, the rate of mortality starts to rise. Over 65, it's quite a bit higher, and then over 75, you know, it's 20%. So I mean, it's pretty scary. And if you have underlying diseases such as diabetes and things like that, again, your mortality is increased. Now, having said all that, so I mean, you could say that if you're young and 25 years of age, you know, don't have to get the vaccine. You don't need it as urgently, as certainly, as the people who are older who have high risk. That is for certain, either because of these risk factors of age or comorbidity, or because of their exposure, like working in the healthcare system, for example. But having said that, there are you know, examples of people who are quite young and healthy who have developed COVID and got into very serious complications, and some who have died. And in addition to that, there is also evidence of what is called long COVID, which means people who got COVID and recovered, who then have symptoms persisting for quite a long time, for many months after. So, you know, arguably, that it is advisable for all individuals to try to avoid this infection if you can. I mean, that's the whole argument also for social distancing applying to everybody, right? But without a doubt, the greatest need is for those people at high risk. And as I told you, it's the older ages, underlying diseases, people who are in community homes, for example, nursing homes, which have very, very high risk of getting infected, and people in occupations which are at particularly high risk, whether it be healthcare workers, whether you're bus drivers, taxi drivers, that type of situation where the risk is much greater, or working in a supermarket, for example. Yep. Over.
So that actually comes to quite an important issue that I think we all need to understand, is the role of the vaccine. Is that protecting you from infection, protecting you from having a severe disease, and how does it affect transmission? Is it actually just because you got vaccinated, does that mean to say now you should go out and you're free to go out and socialize and everything because you won't transmit the virus? I guess this is an important distinction that we should all need to make regarding what it means if you've been vaccinated. And it's effective, but what is it effective for?
Exactly. I mean, I think that is a very, very important point. So these vaccine trials that have been done, the endpoint that is measured is protection from disease, right? Not even protection from infection. We don't know. I mean, it could be that people got asymptomatically infected. We will not know, except for a very small subset in the Oxford trial. All the other vaccine studies essentially have been looking at people who have been vaccinated. They are asked to report any symptoms after that period. And when they report the symptoms, there is a nurse who comes and takes the swab and all this and checks whether it's COVID or not. So there is no measurement on whether you can get asymptomatically infected and whether you can transmit from such asymptomatic infections. Now, unfortunately, many people seem to assume that the two are the same, but the two are not. Okay. Now, one can reasonably hope that the evidence of protection from infection, protection from disease, translates to also protection from infection, and therefore protection from transmission. But we cannot take that for granted. So, I mean, if you take a concrete example, I mean, if, for example, I were to take the vaccine, and I was out and about working, moving in the community, working in the community, and I was going and visiting my very elderly parents or relatives or friends or whatever, I cannot assume necessarily that because I've had the vaccine, I will not be carrying infection to these high-risk individuals. We may get information on that in due course, but at the moment, the evidence is for protection from disease, not necessarily protection from transmission. So I think we have to keep that distinction clear. As I said, we hope that the two have some linkage, but to what extent is still left to be seen. Over.
Okay, thank you very much. I think we are running out of time, but I think we can have maybe one or two questions, which perhaps we can have a quick, I think we'll get a quick answer anyway, which is not to do with the vaccine, but actually to do with living with the virus. There were a number of, I mean, overwhelmingly, most of the questions were all about the virus, about the vaccine, but living with the virus. So there are several questions, and I will just tell you what they are, and you can answer them all at once, right? So one is regarding the quarantine. It says, Professor Malik, you are serving 21 days in quarantine. It used to be 14. Does the benefit outweigh the cost of increasing the days of quarantine, and why not 28 days? Is this arbitrary or really scientific? So that's one question to do with living. And the second one is, can you comment on the policy of continued social restrictions, school closures with a low case number? That is a target of 0 cases realistic?
Right. So in the question of quarantine, I mean, I would dearly wish that it was 14 and not 21 days. But just to give you the science behind it. So the period of quarantine is based on the incubation period. Incubation period means from the time that you get exposed, when do you get symptoms and when do you get virus in your throat, right? And you can transmit to other people. So we know that the incubation period for COVID is about 5 days, what is called the median or the average. But as with everything, there is a curve. So that curve can be earlier, it can be 2 days, and it can go on up to about 14 days. So that was the rationale of the 14 days. Now, the reason for the extension to 21 days is because we know from sequencing of the virus that this 4th wave, and indeed the 3rd wave as well, came from not from re-emergence of the virus in the community that was there, but from external introductions of the virus. So the 3rd wave and the 4th wave were virus coming in, introduced from outside, from travelers. In the case of the 3rd wave, maybe the ship crew and all these things. At that stage, there were all those loopholes. And there has been some data to suggest that, although I'm not completely convinced of the data, that there can be people who may become PCR positive beyond 14 days. So that is, of course, a very small proportion of individuals. So that is the rationale of increasing it to 21 days. Anyway, so, you know, nothing I can do about it. Now, is it
realistic to have 0 cases? That's the question.
Right. So I think the reason why Hong Kong is pushing to get case numbers way down, and you remember back in May and June, we were down to not exactly 0, but it was, you know, indeed 0 for a couple of weeks, and then occasional blips and down. I think the advantage is when you are in that situation, you can relax. And indeed, if you go back to that time in May and June, if not for those external introductions, I think we could have been in a very relaxed state of social interactions. It was those external introductions that led to that problem. So the lower you can get the transmission, the more relaxed you can get to. And I think that is the reason why we are trying to, why the Hong Kong government, the health department is trying to push this down much further. I completely agree that, I mean, relaxing at this stage where we are having 20, 30, 40 cases every day, if you relax now, you're going to end up with a complete burst of infection. I mean, I don't have time to explain this, but there is this, if you look at the School of Public Health, the Hong Kong EU website, there are some nice charts, and there is what is called the reproduction number, meaning the how many people one infected person infects. So the idea, the aim is to get that reproduction number below 1, because once it goes below 1, we then progressively eliminate the transmission. At the moment, this reproduction number is like 0.8 or something like that. So just hovering below 1. If we relax, we will have that going up again to 1.5 and beyond, and then we'll be back where we started. So we certainly do have to go, you know, for longer. I know the pain, but unfortunately, that is the reality. If you want
travel
to,
bubbles are not likely to come soon.
That is a different question. So that is a different question. So I mean, if, for example, you know, I mean, places like New Zealand, places like Australia, where in fact, although there have been occasional outbreaks, where by and large the infection is, you know, more or less completely controlled, quite reasonably can travel between those places. Now, Hong Kong, back in June, that type of period, we definitely could have been, I think, able to, you know, logically able to travel to Australia, New Zealand, etc. And of course, this travel bubble with Singapore being talked about. That is, if you can get the transmission down to that level, then there could be safe travel. And then, of course, there's also the other issue of the quarantine and the testing before and traveling and testing after, etc. So all those can combine to make a travel bubble possible. Yeah.
So you think that a travel bubble, so the last thing is that to say is that Do you think the travel bubble might be realistic with a combination of vaccination and testing, or one or the other?
Yes, so I think, as we said, the question is, with the vaccination, we will be protecting ourselves. We don't know how much it is going to interrupt transmission, so that remains to be seen. So once we have those information, then travel can become safer. But clearly, I mean, I don't think, and I think that the title of this whole session was "Living with COVID." So I'm afraid, going back to normal is probably not something we should be thinking about. And indeed, to be honest, I think we should not be going back to normal. I mean, to be honest, previously I used to be traveling internationally every month, once a month. And right now I'm doing most of the things I'm doing, but doing it through Zoom and all these types of things. Of course, there are some things that you can't replace, physical interactions, but I think we can do a huge amount by alternative means. And I think we should, not only for COVID, but for the climate, for carbon dioxide emissions, for everything, we probably need to change the way we live. And I think COVID is probably a good reminder that we humans are kind of living beyond our means as a species. So on that note, maybe we should end.
So on that note, thank you for those wise comments. Thank you very much. I pass now over to May to conclude the session. Thank you so much, Malik.
Thank you so much, both Kathy and Professor Malik. It's been a very, very interesting session. I'm afraid, like with all these things, more questions than answers, but we are on this journey to normalcy, but it's quite a long journey. But I think the key takeaway is that we should all get vaccinated. The vaccines are safe. Obviously, mutations will occur, but the vaccination should be a starting point. And what is the key takeaway for me is that we will still need to exercise a lot of personal hygiene and wearing of masks, and only essential travel by the sound of it, as opposed to, reckless traveling as what we did before. So what we would very much like to do is also for Professor Malik as a gift to membership of MAYCHAM, complimentary membership, so that we can tap on your knowledge and resources, but also we welcome you to the MAYCHAM family. There is a lot of talent in this network, and as evidenced by today's session, knowledge sharing is so important. We have so much knowledge network in the Malaysian chamber. So let us all work together in 2021 to share this knowledge and create a better world for all of us in the chamber and from outside the chamber as well. So with that, thank you so much, and thank you everyone for dialing in. Many thanks.